Okay, so hello and welcome to the First Friday event. The title is Work Smart, Protect Your Heart, Cardiac Disease and Accommodations. We have two speakers. We have Dr. Thomas Boyden Jr. And Claudette Stork-Reed of MRS. Dr. Thomas Boyden Jr. Is a non-invasive cardiologist and is a board certified in internal medicine. Dr. Boyden earned his medical degree from Stritch School of Medicine, Loyola University in Maywood, Illinois. He also earned his master's degree in health and healthcare research from Rackham Graduate School at the University of Michigan in Ann Arbor. He completed his internal medicine residency and cardiovascular medicine fellowship also at the University of Michigan in Ann Arbor. Dr. Boyden's clinical interests include primary and secondary prevention of cardiovascular disease, hypertension, dyslipidemia, and peripheral vascular disease, PVD. Claudette Stork-Reed earned a BS in occupational therapy in 1975 from Wayne State University. Following a diverse OT work history, she joined the Business Network Division of Michigan Rehab Services in 1998, where she specializes in the use of technology for job accommodations. She works with both businesses and individuals with disabilities to facilitate greater employment for this population. She has held OT offices at the local, state, and national levels, and currently serves on the City Council for Portage, Michigan. So we will get started with Dr. Boyden, and we thank him so much for his attendance.
Thank you very much for having me. So I'm just going to talk a little bit about cardiovascular disease as we see things today. I have no disclosures regarding this presentation. And just a little bit of background on me. As mentioned, I am a general cardiologist. I've been at Spectrum now for about almost 8 years. I was fellowship trained in preventive cardiology at the University of Michigan. I'm also an NIH research fellow focusing on health and healthcare research, as mentioned. And my passion really is in helping people prevent first events from cardiovascular disease or complications from the disease they already have. So we're going to walk you through a little bit about what atherosclerosis, also known as coronary artery disease, what it is, how it's caused, what the complications are that you're likely to see, and how we're treating it. So this is a very slow and progressive process. It can start very early in lifetime. It can start as early as in single digits in childhood, and we see it as fatty kind of cholesterol streaks inside blood vessels. But over the years, it can continue to accumulate as we get buildup of these debris and other substances within the walls of the arteries, such as fat and cholesterol, fibrin and calcium, and other debris. It really begins to not only get inside the walls, but really compromise the function of these arteries as well. So this is a look at a healthy artery. You know, what we're seeing here is, what we're trying to focus on here is this inner layer, the endothelium. That's where really the whole process begins. The endothelium is really just a single layer of cells on the inside of a blood vessel. And it's got numerous functions, but its main function is just maintaining the health of a blood vessel. And once it's damaged, it's kind of off to the races for plaque buildup within the arteries. And so, as I mentioned, you know, in the first decade of life, we can start seeing plaque and fatty streaks start building up within that initial layer of the wall of the artery right underneath the endothelium. And as we continue to age, and mostly through bad habits, whether it's our diet, whether it's sedentary lifestyle, accumulation of other chronic medical conditions, we start to see this plaque really grow and really start compromising the inside of the blood vessel, the lumen, where the blood is, and really narrowing the ability of the blood to flow in the most severe circumstances. So the endothelium is really the link between circulating blood and all of the tissues in our body. It is the way oxygen gets from the blood into the cells. It responds to changes in our physical environment, chemical environment, and even what's going on within the blood and the body itself. It really modulates the tone of the vascular smooth muscle, those layers of muscle within a blood vessel. So it really helps control things like blood pressure. it maintains a really non-adhesive surface, a nice smooth surface, so that hopefully it does not allow the buildup of plaque. But importantly, it can help us with blood clotting when needed, cellular proliferation when needed. It helps recruit inflammatory and immune cells when they're needed to repair damaged tissues. So it holds many responses and many functions within the body, and it's really necessary to maintain that health of that endothelium. When it's injured, it really disrupts all of those mechanisms. And so really when we develop plaques and it's already been damaged, we're really looking at endothelial dysfunction. And the more dysfunctional the endothelium is, the more severe disease typically is. When there is endothelial dysfunction, you can get squeezing or spasm of the arteries. We see this oftentimes in people with heart disease who are out in extreme cold weather. They're breathing in cold air, and that can lead to vasospasm, and that can cause heart attacks or arrhythmias. It can lead to unwanted clotting inside the artery, such as a thrombus. We see this in heart attacks and strokes. The plaque deposition we just showed, that's the process of atherosclerosis. And when it gets really severe and narrows the artery, we call that stenosis, and that's what happens with the arteries in the heart. That's why we end up putting stents in people who are doing bypass surgery. And so we see a real strong correlation between endothelial function or dysfunction between many chronic conditions and risk factors for coronary artery disease. We see this with high cholesterol, high blood pressure, smoking, diabetes, and very importantly, sedentary lifestyle and nutrition. So these are really the effects of atherosclerosis in the body. Anywhere there's an artery, there's the potential for plaque buildup in that artery. And the most common and severe consequences involve the brain and the heart. You can get vascular dementia because of plaque buildup in the arteries of the brain. You can also have stroke because of this plaque buildup. This is the same process that causes heart attack. And heart attacks can lead to scar tissue forming in the heart and heart failure. But you can also develop heart failure without heart attack if your blood vessels get severely diseased, that they're not allowing oxygen to get to the muscle tissue of the heart, and it just doesn't function as well. We see the same process happen in the kidneys, where plaque builds up in the arteries of the kidneys, leading to the kidneys and its tributaries within the kidneys. This can cause chronic kidney disease and worsen chronic kidney disease, and oftentimes as a result of people on end-stage renal disease where they develop the need for dialysis. And we also see this in peripheral arterial disease, people who develop severe symptoms of claudication or narrowing of the arteries where the blood flow is not normal, and it's painful to do things such as walking. So it's incredibly important to put all of these processes in our heads in terms of how we're treating the patients, because if we see this anywhere, we know it can be everywhere. So what's really driving the risk of this coronary artery disease or atherosclerosis? It is by and away predominantly lifestyle. So we see that, over the course of a lifetime, people who stay very active, who eat healthy, who are maintaining healthy weights, not smoking, who really are focused on their health, there's very little chance that they're going to develop atherosclerosis and the complications of it. But as you look at the statistics within our own country, over the past several decades, we have seen a dramatic rise in the weight of our country on an individual basis. There are more people obese today than there ever have been in the history of our country. Those figures, unfortunately, continue to rise. And obesity is not in itself a direct cause of coronary artery disease or heart disease, but it is significantly impacting the risk factors that impact cardiovascular disease. So it can lead to things like high blood pressure, high cholesterol, high triglycerides, diabetes. All of those things directly impact the health of our blood vessels. Diets play a major role in this too. Our diets have become more and more reliant on processed foods and animal-based foods over the past several decades, really since probably the 1950s or so. And as we continue to have poor diets, we continue to see the worsening of all of these chronic medical conditions that I just named. And we have more and more difficulty controlling these things with medications because we really aren't changing the underlying things that are driving these chronic medical conditions. And when we look at things like diabetes or hypertension or high cholesterol, they have huge impact on the risk for heart disease. So hypertension can triple the risk of heart disease. We know it's involved in most strokes. Diabetes doubles the risk of heart disease. High cholesterol is driving the risk of heart disease and heart attacks by at least 30 to 50%. And you can see this in the why, kind of, I talked about this, but I really want to stress the importance of this. So we're really seeing our health disappear right before our eyes. Over the past several decades, as I mentioned, our diets have gotten worse. We've become more sedentary, whether that's because of how our work has shifted to more sedentary work rather than more factory-based work or farm-based work. But less than 3% of our country can currently claim that they eat healthy, maintain a healthy weight, get adequate physical activity, and avoid tobacco. It's less than 3% of our country that can claim all 4 of those things. So it's not surprising when you realize how few people can do this that we're seeing the statistics worsen on an annual basis. So just as a quick little question here, what % of patients do you think could avoid cardiovascular disease through lifestyle alone? I'll give you a couple of seconds here to think about that, and then I'll show you the answer. So it's actually 80%. The prediction is that if we all follow these healthy lifestyle habits and maintain a good weight, that more than 80% of the population would avoid cardiovascular disease and its complications. And it's not just cardiovascular disease that these lifestyle habits are really causing. Not only is it causing heart disease, but it's really starting at these chronic conditions like diabetes and hypertension and high cholesterol before it's developing heart disease and stroke. But it's also causing chronic kidney disease, which accelerates the process of that atherosclerosis. Our habits are definitely linked with cancer risk. And as while we've made incredible breakthroughs with cancer treatment, we're still seeing high rates of the development of cancer, predominantly because of lifestyle. So it's really important that we get these things under control, because over 60% of our country currently has at least one of these conditions, and 40% of our country has 2 or more of these conditions. And the more of these conditions we have, the worse our health and our health outcomes are. When you look at this chart, this is just looking at causes of death. Heart disease, cancer, and stroke make up essentially half of all deaths in this country. And so this is a real opportunity for us to take control of and improve. And it's mostly done through lifestyle. It's not the medications, it's not the medical procedures, but it's really done through lifestyle. I talked a little bit about this already. With regards to hypertension, I did mention that, up to 80% of patients who have strokes have hypertension. But hypertension not only is it linked with coronary artery disease, it is a cause of heart failure. It can cause arrhythmias like atrial fibrillation, which increase the risk of stroke. It causes aorta disease, such as aneurysm, because of the high pressure within the aorta. It can accelerate valve disease like aortic stenosis, and it is directly linked with sudden cardiac death. So all of these things, as mentioned, are very controllable through lifestyle, but have huge impacts on our health, in particular our cardiovascular health. When you look specifically in Michigan, 1 out of every 3 deaths in our state is due to cardiovascular disease. We spend more than $17 billion a year on cardiovascular disease. We spent $17 billion in 2010. We're spending over $500 billion in the United States on cardiovascular disease. That figure, 17 billion, was for the year 2010. And that has continued to slowly increase over the years. Heart disease is the #1 cause of death in Michigan and throughout the nation, and stroke is now the #4 cause of death in our state. And so I've done a lot of work with the American Heart Association as well, and they have really tried to simplify the approach for individuals by focusing on what they're calling Life Simple 7, which is get active, control your cholesterol, eat better, manage your blood pressure, lose weight, reduce your blood sugar, and stop smoking. And I would really tell you, I think this could be simplified to Life's Simple 2, which is get active and eat better. And the reason I say that is when we are active and we eat better, we have better control of our cholesterol, our blood sugar goes down, our blood pressure goes down, we naturally lose weight through mostly better nutrition. And so if we could really focus on those two things, we would impact 6 of Life Simple 7. Obviously, smoking is not going to be impacted by physical activity or our diets, but we would have a huge, huge impact on these known risk factors just by getting more active and eating better. And I'm going to show you a little bit of that next. So what are diets that we're recommending to our patients? I like to start with the Mediterranean diet, at least in its concept. It does not have to be foods directly from the Mediterranean area, but more about how they're eating, the way they're eating, which is mostly based on a plant-based diet at the bottom of the pyramid being the most of the foods you're eating in the course of a day. So this is fruits and vegetables, whole grains, nuts and seeds, leafy greens. So that should be the basis of everybody's diet. And when you start thinking about adding in things that are not plants, you should think about seafood over land-based food, animal foods, because in general, these seafoods have less of the unhealthy fats and more of the healthy fats, and they cause less disease. And we should really minimize the amount of food we're getting from land-based animals such as dairy and meats. And if you think about what the base of this period is of the Mediterranean diet, that leads to the next diet that we talk to our patients about, which is a whole food plant-based diet. So this really is getting rid of all of the animal products in the diet and just focusing on plants as a way of eating. And a lot of people think they can't get enough protein through this diet. I can tell you wholeheartedly and through personal experience, you can get all of your protein needs through a whole food plant-based diet. You might have some vitamins you need to supplement, like B12, but other than that, you are really getting all the nutrition you need. And the more plant-based foods you're eating, the better micronutrients, vitamins, minerals you're getting compared to these processed food diets and animal-based food diets, where we're not really getting any of those micronutrients, vitamins, or minerals. I like to compare what we do with medications to what we can do with diet. This is one of many examples of cholesterol medications compared to placebo and how that affects cardiovascular risk over time. So on this bottom axis here is time, and on this upper axis is cardiovascular risk. And when we do clinical research, we're really looking for separation of these curves to say, how long does it take before we see a difference between treatment versus no treatment? And is that treatment difference significant? And atorvastatin is the medication Lipitor, which has been around for decades and is one of the most potent cholesterol medications we have. And as you can see here, it takes a full year of taking that medication before we start seeing a change in cardiovascular risk. Compare that to the Mediterranean diet, which was run in a very similar randomized controlled trial. And what you see here is a separation of the curves within weeks of starting the diet. So I can tell somebody in my clinic, I can get you to change your cardiovascular risk in a couple of weeks if I can convince you to change your diet. If I start you on medications today, it's probably going to take a full year or more before we start seeing that change in risk. There's not much more powerful data I have when I'm talking to patients to show them these things. It's really a pretty profound example of what we know in the clinical literature and really what we should all be teaching our patients. The benefits of the Mediterranean diet are very, very good, not just about cardiovascular disease, but overall mortality, reduction in cardiovascular death, reduction in the incidence and death from cancer. It reduces the incidence of Parkinson's disease and Alzheimer's disease. And when you get to these whole food plant-based diets, you can even see what we have never been able to show through drug trials, and we don't do through medical procedures, but you can see disease reversal. If you look at this illustration here, the panel A is a very diseased artery. If you think back to that illustration at the beginning of this presentation where the plaque was built up and narrowing the vessel, that's what this looks like when we're in the cath lab. And this is a healthy blood vessel, nice and smooth the whole way through, the same width the whole way through. This was the before picture, and panel B was the after picture. And this is all based on diet, a whole food plant-based diet that's low in fat and low in oil. This individual did not even take cholesterol medications while he was maintaining this diet to be able to change the disease in his body. So what I can tell you wholeheartedly is that disease reversal can happen with diet. It does not happen with medications. We know it just stabilizes disease. And medical procedures don't really change the disease at all. They just change the symptoms, or they go around the disease when we talk about bypass to improve blood flow around the diseased vessel. So plant-based diets have very similar benefits to the Mediterranean diet. In addition to cardiovascular disease reduction, it shows significant improvement in diabetes, hypertension, high cholesterol, depression, gene mutations. It helps heal the DNA and the RNA in the body, reducing cancer risk, helps people achieve healthier weights, reduces inflammation. And the one thing, and the Mediterranean diet does all of these things as well, but the one thing the Mediterranean diet has not been shown to do that the whole food plant-based diet has is that disease reversal. With regards to activity, this again is why I wanted to focus on Life Simple 2. We know that increase in physical activity really has a huge impact on cardiovascular risk. So if I can get people to go from being sedentary to doing something as simple as taking a 30-minute walk a day, there is about a 30% reduction in cardiovascular risk. And the more we exercise, the more risk reduction there is. But the biggest drop in risk reduction is just getting off the couch and getting active. And so people don't need to join gyms. They don't need to buy special equipment. They just need to get more active, increasing the heart rate, increasing the breathing rate to get those cardiovascular benefits. So thank you very much. If you have any questions, I'd be happy to answer them now, or if we're doing them at the end of the presentation, I can wait till then.
So hi, Dr. Whiting, we do have some questions. So
Sure.
I'll go ahead and read those off. So one is, once you have a diagnosis of CV disease, can it be reversed with a change of lifestyle?
Yeah, absolutely. I'm going to flip back through my slides here. That is exactly what this is showing. So this is an individual with cardiovascular disease or coronary artery disease. This is the same person in panel A and B. This is the before picture when they were having symptoms of angina, so they were taken to the cath lab. And when we injected dye into the arteries of the heart, we found this very diseased vessel. And this individual had the option of what we normally do, which is putting a stent in this. So we actually first put a tiny little balloon in there. We expand the balloon, breaking up all the plaque. The vessel is still damaged and diseased. That endothelium is still damaged. So there's still the possibility of plaque building up in there. And we put the stents in there to hold the vessel open to improve the blood flow. That reduces the angina, the chest pain that people have. It doesn't change the disease. It doesn't change the risk of heart attack or the need for a future stent, because the endothelium is still dysfunctional and is still susceptible to that same process. But the lifestyle of the diet change, being very active, managing stress, over the course of 2 years, 2.5 years, this individual completely reversed their disease. And that's what this is showing here, panel B. This is the after picture with no intervention on that artery other than the lifestyle change.
Great. Okay. And then if you have arteriosclerosis or arteriosclerosis, can it be reversed?
That's exactly what we just talked about.
Okay.
Yep.
Okay. And how can you determine how much protein you need when you are eating plant-based? I tried plant-based eating and it was great. After a while, I was struggling with weakness, bones cracking, and it made me fearful.
That's a great question for a clinical nutritionist because they can really help guide you with what you're doing plant-based and making sure that you're getting enough protein. There are definitely foods that have more proteins than others. I would kind of steer you toward leafy green vegetables like spinach, kale, Swiss chard. All nuts and seeds have a lot of protein in them. Beans and legumes have a lot of protein in them. Certain grains, but not all, have a decent amount of protein in them. But if you really want to figure out the exact needs, clinical nutritionists are really excellent at this and are really worth your while because they can spend a whole hour or more with you. Most insurance covers several visits with a clinical nutritionist, particularly if you have any of those chronic conditions we talked about at the beginning of this presentation. And they can really help steer your nutrition to not only improve your health, but regain it because most of those chronic medical conditions like high blood pressure, diabetes, high cholesterol, and even coronary artery disease like I'm showing here, they're all reversible. So if we get control of what we're doing from a dietary and physical activity perspective, we can reverse all those chronic conditions.
Is there no other way to get B12 or any nutrients besides supplements? Interested in a plant-based diet, but would not want to take supplements unless absolutely necessary. Thanks so much.
Yeah, B12 unfortunately mostly comes from meat. And again, a great question for a nutritionist about where you might be able to supplement this in the diet. But I think most people who are completely plant-based do take some B12 supplementation.
Mhm. And then there's a question asking, can we please get a copy of this presentation?
That's fine by me.
And I had a PFO procedure in 2021. I am working out again. What are my risks of heart disease and how long should I monitor for risk?
So the PFO is a congenital thing. So what that means is patent foramen ovale. And really, we all have that in utero. So when we're in the womb, that is the way that the mother's oxygen and her bloodstream gets to the fetus. After we're born and we start breathing, that patent foramen ovale at the top part of the heart closes off. And in some cases, it remains open and it can predispose people to things like stroke. And so oftentimes these things are closed. The fact that someone has a patent foramen ovale does not mean that they're going to develop coronary artery disease. So they're pretty independent of one another. So really it's going back to what we talked about. If you think about 80% of coronary artery disease or atherosclerosis being preventable, it's really about your lifestyle habits. And so even if you've had a PFO or a PFO closure, I would still encourage you to focus on lifestyle as the main way of reducing risk.
Then we have a comment. It says, thanks, Doc. I got off the couch and made myself a salad.
Glad to hear that.
Also, there's another question that says, does drinking apple cider vinegar with water help break up plaque, help clear arteries?
I know there's a lot of information out there about that, and I can't really answer that question. And the reason I can't answer that question is because we don't study things like that. We do see things like vinegar potentially helping cholesterol. I can't tell you that it helps break up plaque. And based on what we know about really potent ways of lowering cholesterol, I don't know that something as simple as apple cider vinegar would reverse plaque. But if you come over to this kind of whole food plant-based diet and you really give up animal foods altogether, and for the most part processed foods, you can reverse plaque. We know that has been shown in clinical research.
What percentage of arteriosclerosis and atherosclerosis comes from smoking? Also, can you combine both plant-based and Mediterranean diets?
So smoking is a major, major risk factor for heart disease and arterial disease. Smoking is just an absolute wild card because I have seen, what I tell every patient is if you smoke, you're going to get one of three things. You're going to get vascular disease, like we've been talking about. You're going to get cancer, or you're going to get emphysema. And you might be lucky and get only one of them. You might be unlucky and get all three of them. None of them are good things. And so I really encourage people to put that in perspective so that they can help break one of the hardest habits to break. But smoking is a huge risk factor for heart disease and peripheral vascular disease. So most people with peripheral vascular disease are smokers. And it is a very debilitating disease because the arteries in the legs are closing off. People get ulcers, they get infections, sometimes they lose limbs. Before that happens, usually they have a very difficult time just walking because of the pain that is caused by the lack of blood flow when they're moving. So smoking, if you're a smoker, there are definitely programs that can help. We use a program called Pro Change at Spectrum. It's really about behavior modification. It's not about medication. But there's medications that can help with it. And you just really need to talk to your doctors about how they can help you break that habit. Plant-based diets, I do consider the Mediterranean diet to be plant-based. It is a plant-based diet that doesn't kind of force you to give up animal-based foods if you don't want to altogether. But the majority of the diet should be plants, and the side dish, if you will, should be the animal-based foods.
Okay, Dr. Boynton, we have one last question, and it says, does genetics play a factor in heart disease?
It absolutely does, but I would tell you, for the most part, that's why we see about an 80% reduction in cardiovascular disease through lifestyle. That other 20%, there are genetic conditions that can predispose people to heart disease. So, you know, if you're worried about the genetics or the family history, definitely talking to your primary care doc or a cardiologist is a great idea. I see lots of people with strong family history of heart disease. I go looking for genetic causes of their family history. And there's a lot of things that are there genetically that sometimes people just don't recognize, whether it's themselves or their doctors, just because they're not really well known and we haven't had great treatments for them in the past. But fortunately for us, those things are changing. We've got new medications coming out that really help treat a lot of these genetic conditions, and we can kind of return risk back to a normal level, even though you might have abnormal genes.
Okay, and sorry, Dr. Bowden, there's one more here that says if you stop smoking and use the diet, can the condition be reversed?
Absolutely.
Okay, well, Dr. Bowden, we thank you so much for your participation and all the great information that you've provided. Is just, it's really good to know. It makes you think twice. So thank you so much.
You're very welcome. Thank you for having me.
You're welcome. Bye-bye.
Bye-bye.
Okay, so next up is Claudette, our very own. And so we'll let you take it away.
Okay, let me grab my screen. Okay, can you see the screen?
Yes.
I think we're good. All right. Thank you very much for asking me to come here today. And I am going to be talking about cardiac accommodations. And so what we're looking at is that the term heart condition includes many different conditions: high blood pressure, coronary artery disease, congestive heart failure. Each of those conditions has its own symptoms, such as angina, sensations of fluttering, thumping, pounding the heart, edema, lightheadedness, weakness, dizziness, fainting spells, breathlessness, fatigue, and gastric upsets. These symptoms can be acute or chronic. And so we have a lot of things going on when we're talking generally about heart conditions. People with heart conditions may develop some of the limitations that will be discussed, but seldom do they develop all of them. Also, the degree of limitation is going to vary between individuals. So be aware that not all people with heart conditions will need any sort of job accommodations to perform their jobs, and many others may only need a few accommodations. The following is only a sample of the possible ways that people can be accommodated. Many other accommodation solutions exist. So first, I would want to have some questions that you want to consider when you're talking about accommodations for a worker with cardiac issues. What functional limitation does the employee experience? Remember that a functional limitation can relate to a body system, so that breathing or shortness of breath can be a limitation. How do the limitations affect the employee and the employee's job performance? Not all performance issues are caused by an employee's disability. How is the performance issue related to the functional limitations? What specific job tasks are problematic as a result of these limitations? Are they essential job functions or marginal tasks? And how frequently are they performed? What accommodations are available to reduce or eliminate these problems? Are all possible resources being used to determine potential accommodations? And has the employee been consulted regarding possible accommodations? The ADA interactive process should assure that the employee is actively involved in the process of identifying and implementing accommodations. Once the accommodations are in place, it's important to meet with the employee to evaluate the effectiveness of the accommodations and to determine whether any additional accommodations may be needed. And lastly, do supervisory personnel or other employees need training about the issues or about accommodations in general? A good way to think about accommodations is that they're like a bridge that spans the gap between what a job requires and what a qualified worker with a disability can do because of the disability-related limitations in function. The kinds of functional limitations you will see with someone who has cardiac issues are often related to a decrease in good circulation to organs or a general decreased tolerance for activities, especially ones that require increased breathing, rapid movements, or large muscles against gravity. You notice unlike the doctor, I'm not talking about the underlying disease process or making any changes. I'm talking about the impact of the functional limitations and how that relates to somebody's working. So we'll take each one of these areas one at a time and see how a worker experiencing these functional limitations might be accommodated on the job. Workers with decreased balance may have difficulty moving around the worksite. Some options provide support, such as canes and walkers. Others reduce the energy required to move about, such as using scooters, wheelchairs, or stair lifts to go from one level to the next. Jobs that require working at heights are an obvious problem for those with decreased balance. Consistent use of fall protection safety equipment is critical, and consideration may be given to aerial lifts or modified ladders with wide wheeled bases and handrails. Working safely for persons with decreased balance may mean increasing the use of personal protective equipment or providing additional padding in the worksite to protect the worker in case of a fall. Accommodating a worker with dizziness can be similar to that for a person with decreased balance. Now, some types of lighting, like fluorescent lights, can trigger some dizziness for some people. And using a vehicle rear vision system or a camera eliminates the neck movements that can trigger for some people who experience dizziness. Recognize that a change in the work process can also be helpful too. Having flexibility in schedule of start and stop times and break times can allow a worker to better manage intermittent dizziness. Working from home can allow for position changes, micro breaks, and other methods of managing dizziness. Here's one example of accommodating a worker with decreased balance. The employee working on the 10th floor of a large office building has orthostatic hypotension, a form of low blood pressure that happens when you stand up from sitting or lying down. This can make you feel dizzy or lightheaded and may even cause you to faint. This worker expressed concern about taking the stairs to evacuate the building in case of a fire or other emergency. An evacuation chair was purchased, and several of her coworkers were trained in how to assist her in safely and quickly evacuating the building in the case of an emergency using the new chair. The chair that's pictured is from the EVAC Chair Corporation. Evacuation chairs have tracks or rollers to allow safe movement downstairs. When a worker experiences decreased stamina and he's easily fatigued, mobility about the worksite can be an issue. Elevating wheelchairs not only assist someone moving from place to place in the facility, they can also raise to a higher level, eliminating the need to stand to reach materials or equipment controls. Wheelchair mounts can support cell phones, tablets, or laptop computers, allowing the worker to have access to devices while remaining mobile. Energy conservation techniques allow workers to do a task differently, expending less energy to accomplish the same task. Wearable anti-fatigue matting can be strapped to a worker's shoes. This allows them to stand and walk using less energy and having more comfort. Examination and procedure chairs are useful for jobs which have tasks where you have a prolonged forward leaning, such as a lab technician, hairstylist, or a dental hygienist. Stand lean stools are specialized tools which take part of the weight when the worker stands, reducing fatigue for tasks that require prolonged standing. Changes in the work process can also reduce the amount of energy required to perform tasks. Worksite redesign or a modified workspace can make a job task more efficient by bringing materials closer to reduce the amount of walking, reaching, and lifting. Periodic rest breaks allow a worker to recover during the workday before they're so fatigued that they can't continue. This may mean dividing a 15-minute break into 3 5-minute mini breaks, or increasing the total break time by extending the worker's shift. Job restructuring is generally considered when other accommodations are not possible or effective. When a worker with stamina limitations can perform most of the essential functions of the job, it may be reasonable to consider redistributing job tasks that cause the greatest fatigue to other workers. Here's some examples of equipment that may be helpful with stamina issues. This is an Action Track all-terrain wheelchair. It can navigate outdoors over uneven or shifting terrain, which requires a great deal of additional energy when walking. I recommended this for a worker who was a master electrician and worked frequently on construction sites. Impacto Ergomate anti-fatigue footwear allow anti-fatigue mats to move along with the worker. And this examination and procedure chair was designed for use for dental hygienists who must lean forward when working. The C-shaped support holds the upper body weight against gravity instead of using their muscle power. Here's one example of accommodating a worker with decreased stamina. A taxi driver returning to work after a myocardial infarction experienced reduced stamina, and this was worse when he was working on his usual midnight shift. As an accommodation, his employer required that he be scheduled only for day or afternoon shifts to address his increased fatigue during the night shift. Persons with cardiac issues often have lifting restrictions. I was thinking about lifting in agricultural or farm settings, and I remembered that years ago, I saw a photograph in the newspaper of a woman holding a full-grown cow. She said she started lifting it one day when it was a newborn calf and did it every day, and it just kept growing. For persons who have limitations in lifting, an animal lift table, which uses power and hydraulics to lift farm animals, would be a much better option. In industrial settings, businesses have tried to reduce or eliminate lifting for all workers as a way to prevent injuries. Many of those devices can assist workers with cardiac issues who have limitations in lifting. For example, vacuum lifts use suction to grab onto an object and then be able to lift it. It makes the process quick and easy, two things that greatly increase the likelihood that it will be used consistently. Work platforms can raise the work to a level that allows sliding of items rather than lifting them. When dealing with lifting items in an office or retail setting, we usually think of lifting items up high above shoulder level as the biggest problem for workers. However, when items need to be lifted or positioned below waist level, a worker must support their body weight as well as the item being lifted while bending or stooping. Using a low task chair or stool when lifting items to lower levels allows the worker to remain seated. Other lifting situations that come up, one I really like are drywall and wallboard lifts, and they support the weight of a sheet of drywall on a wheeled elevated scaffold, which greatly reduces the amount of energy necessary to get it into place. Lifting and carrying items on stairs can be a doubly difficult task. Battery-powered stair climbing hand trucks reduce the energy required and allow this task to be performed much more safely. So here's one example of accommodating a worker with decreased ability to lift. Stacking paper and filling the copy machines are typical tasks in an office environment. Workers with lifting restrictions can have problems completing tasks such as these. In this situation, a worker with high blood pressure was limited in lifting to no more than 20 pounds. Typically, a case of copy paper weighs 40 pounds. A wheeled dolly was provided to retrieve cases of paper from the central storage area. In the office, the case was opened and individual reams placed on the shelves while seated in a low chair. Cardiac issues often result in respiratory distress or other breathing problems. Air cleaners and purifiers can be helpful when things in the air are a trigger for respiratory problems. Air cleaners have become very specialized, focusing on the particle size and the type of trigger, such as petroleum distillates that are used in scented products that trigger reactions for some people. There's even a neck-worn air purifier that can reduce the presence of airborne particles directly adjacent to the person having the problem. These tend to work best for larger particulates like dust and pollen. Protection and exposure reduction is another option for addressing respiratory issues. We certainly have been dealing with face masks recently due to the COVID pandemic. And there are face masks that address specific triggers and even ones which have additional power so that the effort to breathe through the filter of the face mask does not cause greater difficulty. Improving air circulation in the room can also reduce the intensity of odors and other things to a more tolerable level. You need breath control in order to speak, so those with difficulty breathing may also have difficulty speaking. Speaking supports, such as amplifying the outgoing audio on a telephone or using a personal voice amplifier, can address this. So here's one example of accommodating a worker with respiratory distress and breathing problems. An individual with coronary artery disease noted severe difficulty breathing. This was exacerbated by an allergic reaction when exposed to petroleum distillates, such as perfumes, lotions, and hair products. She requested one of two accommodations for this: banning all perfumes and scented creams and hair products from her floor of her building, or working from home as a reasonable accommodation. Her employer determined that the job could not be completed from home due to the confidentiality of the materials she routinely dealt with. And because the public came into the building and it had a centralized HVAC system, there was no way to isolate one floor from scented products. Oops. She was moved to a fully walled office, and a specialized air cleaner designed to remove petroleum distillates from the atmosphere was used. She attended all of her meetings virtually. In addition, she was allowed to modify her schedule so that she arrived and left at a time when there would be fewer others in elevators or stairwells. When you're in a cold environment, your heart has to work harder in order to keep your body warm. In the same way, when you're in a very warm environment, your heart must work harder in order to cool you off. Persons who have cardiac issues are often sensitive to temperature extremes and may not be able to take this additional strain. Steps can be taken to either modify their temperatures or change the environment. Cooling clothing, fans, and portable air conditioners can lower a worker's body temperature. Heated clothing, like gloves and socks, heated tools, and space heaters can raise a worker's body temperature. Air deflectors and vent covers reduce exposure to overly hot or cold air. So here's an example of accommodating a worker with temperature sensitivity. A manufacturing engineer with a heart condition was restricted from working in extreme temperatures. Her job required that she obtain data and product from the manufacturing floor and do tests on safety and product quality. Her lab was temperature controlled, but she had to go into the manufacturing floor several times a day for up to 30 minutes. The plant was not temperature controlled, and it was very hot in the summer and very cold in the winter. She was provided with a thermal vest made of material that could retain heat or cold. It could be placed into the microwave or into the refrigerator and then used to maintain her core temperature while she was on the plant floor. She also collected the samples more frequently, so the time she was exposed to the extreme temperatures was shorter. One of the activities that can involve issues of fatigue, limited stamina, balance, and respiration is walking. We've already talked about many of the possible accommodations related to mobility on the worksite. One you might not have considered is being able to get on and off of a boat. This may require additional ramping, handrails, or lifts for workers who use mobility devices like scooters or wheelchairs. Making walking less energy intense can help as well, which can sometimes be as simple as taking a longer, flatter route instead of the shorter route that includes uneven terrain or stairs. One example of accommodating a worker with limited tolerance for walking is temp agencies are a great way for workers with disabilities to gain experience. They also require dealing with different issues that may come up at each worksite. In this example, the parking area for employees was distant from the worksite, creating difficulty for the temp employee with a cardiac issue due to his limited tolerance for walking. He notified the temp agency, his employer, who then called the company contracting for his service, the temp agency's customer, and they requested a reserved parking space close to the building. As they deal with the treatment for their cardiac conditions, many workers run into work-related issues for their medical management. These can also be opportunities for reasonable accommodations. In situations where medications cause some difficulty with focus or memory, additional training time or refreshers may be needed. Taking cardiac medications consistently is important. Reminders can be placed on computers, cell phones, or a separate wearable device to assist with this. And having a flexible schedule or allowing for remote work can assist with managing the time needed for medical appointments. Today, maybe more than ever before, businesses recognize the value of their employees and they want to retain their experienced workers. They are motivated to find accommodations which will allow workers with cardiac issues to return to work and continue to work safely. Following the interactive process, as outlined in the Americans with Disabilities Act, facilitates businesses to identify and implement reasonable accommodations that will help their workers return to work and stay at work. Any questions?
Yes, Claudette, we have a few here. If an employee is hired and has cardiovascular disease and may need accommodation to function on his or her job, do you discuss this before or after hiring?
When you are interviewing someone, you can ask them if they feel that they can do the job with or without accommodation. You can't ask them what their disability is or specifically what it is that they may need as an accommodation, so that you hire them based on their qualifications. Once they have been hired, at that point, you would, if the employee requests an accommodation, you would be looking at what needs to happen in that process.
Okay, we have another one here. In reality, I'm thinking that these devices are expensive. Do you think that an employer would provide any of these accommodating equipment for an employee who has cardiovascular disease to do his or her job?
Actually, most accommodations are not that expensive. Some of the things that you've seen have, are changes in process, but recognize that if you can reduce the amount of energy that is necessary to do a job, it's going to improve the job, not only for the person with cardiac issues, but for other workers as well. Employers are very motivated at this time to be able to provide accommodations for persons with disabilities, including cardiac issues, because they want to retain their experienced workforce.
And when seeking appropriate, reasonable accommodations, is there a website or a book to reference?
One of the best places to go is the Job Accommodation Network, or JAN. And the website is askjan. I think it's .org. And they have information based on diagnosis, information based on limitation that the person has. And they also have people who work there. You can ask a very specific question and they will help problem solve for you. In addition, the Business Network Division of Michigan Rehab Services has occupational therapists who can assist in assessing and identifying potential accommodations to help with the interactive process. And don't forget that that person who you are working with, that employee, knows more about their issue than anyone. And so they're going to be a great resource as well.
And one other question here is, can I request the PowerPoint and the audio?
Not sure about the audio, but you can certainly have the PowerPoint.
Yeah, I think we have one more. Who would be responsible for paying for an all-terrain wheelchair? It may be used other than for work.
Okay. I've only recommended one of those. And in that situation, MRS was the one who paid for it. And part of the reason was that this was the gentleman's own business who was working. So it's going to be a situation by situation thing. A wheelchair generally is durable medical equipment, And of course, you'd have to look at any other comparable benefits. And so if they have medical insurance that would cover, you would go to that first. In a situation where that type of a wheelchair is being used specifically because there is an issue on the job, then that would be something that the employer may need to be considered as one of the ways to get that paid for.
Okay, and how do we go about obtaining the PowerPoint for both speakers?
That's, you can probably answer that better than I.
Okay, and I didn't know if you, but if you want to go ahead and send your email address out to me, it would be great. You can send that to Belcher, BELCHERN @michigan.gov, all one word, and we will make sure you get both PowerPoints for both speakers. And I think that's all the questions that I'm seeing. So we definitely want to thank Dr. Boyden again and Claudette for supporting us on and sharing with us on how to work smarter to protect our hearts, as well as to give us information as it relates to accommodations as we think about cardiovascular disease. So again, thank you, Claudette, and everyone for joining. We really appreciate it. Have a good afternoon.